A very good afternoon, everyone, and welcome to the Medico-Legal Society of Malaysia's Public Forum. We are really delighted to welcome so many of you this afternoon. And today we will be talking about navigating the COVID-19 storm, featuring some amazing speakers who will be tackling this from various important perspectives, including views from the eye of the storm. While many of us have been stunned by the impact of the COVID crisis before this, and especially last year, now the realities on the ground are becoming norms. Grappling with COVID-19 has become now a matter of luck or the law. For the next 2 hours, we will be hopefully enriching your knowledge and increasing your appreciation for many of the issues that are involved. To kick us off, we will have a personal insight from a COVID-19 patient. What makes him very special is that he is a frontliner and someone very special to the MLSM family. His perspective will be an important one to many of the listeners as well here today who are also frontliners. It is now my pleasure to introduce the first speaker of the afternoon, Dr. Ariffin Marzuki bin Mohktar. And give me a few minutes to introduce him. He is a national specialist registered anesthesiologist. He graduated from the University Kebangsaan Malaysia, UKM, in 2002. And currently, Dr. Ariffin lectures medicine at the School of Medical Sciences, University Science Malaysia. His clinical specialty is cardiothoracic anesthesia and critical care with multiple special interests, including pain management and mechanical circulatory support. Now, apart from his clinical expertise, Dr. Ariffin is a certified IT architect with an impressive list of certifications. He has served as a Deputy Director, Operations for Hospital University Science Malaysia, and currently is the Hospital's Management System Coordinator, Hospital USM. And what that means is that he coordinates the operation and information, communication and technology initiatives of the hospital. In short, he's a techie, a medical techie. Now, his commitment to developing ICT initiatives and resilient knowledge management system is something very valuable, and he assists all of us in MLSM very regularly with tips from his trade. His incredible CV includes his previous appointments as a consultant anesthesiologist at IGN in KL, where he was involved as well in enterprise architecture and accreditation activities. Now, it is no secret that Dr. Ariffin is a valued member of our Medico-Legal Society of Malaysia. And in fact, he is part of a focus group looking into mental capacity issues, which will be one of MLSM's public-private national initiatives. Dr. Ariffin has delivered numerous lectures on diverse topics, including pain management and a whole long list, which I'm not going to read out, but you will certainly be able to appreciate from what I have explained earlier. What is consistent and apparent about Dr. Ariffin is his passion for aiming for high quality and safe care to patients. And that includes competency building for healthcare providers using technology tools and the development of appropriate clinical pathways. Now, clearly, Dr. Ariffin has much to contribute to the medical landscape and the medico-legal landscape, and we are looking very much forward to this. Having said all this, Dr. Ariffin is here in a very different capacity today. He has an extraordinary story to share from a very different vantage point, and that is from the perspective of the patient. Patient who found himself on the receiving end of very intensive care, having been struck down with COVID-19. His perspective will be both sobering and uplifting, and we will kickstart this very important seminar in a question and answer format. And it's my pleasure to get to the heart of things, Dr. Ariffin. I'm sure the audience would like to get an insight into your journey before, during, and after you were tested positive with COVID-19. So perhaps I can kickstart this chat. If you could share with us your involvement as a frontliner, the risks you were exposed to, and how you felt when you found out you had tested positive. And we will take it along in a conversational style this afternoon. Take it away, Dr. Ariffin.
Right. Thank you, Madam Shanti. A very, how should I say, a very kind introduction. I'm just a
Much
simple,
deserved one.
to tell you the truth, I'm the simple anesthetist who is actually doing a lot of difficult work. Yeah, thank you very much for the introduction, and thank you for MRSM for inviting me. And I know this actually started off as a, like a sharing session in one of our meetings, and then you asked me to sort of like share. Okay, to start answering your question, as an anesthetist, I'm actually involved with the acute care and resuscitation of patients, including patients who undergo surgery. And one of the procedures that we do, the aerosol generating procedures, for example, intubation, and also what do you call that, bronchoscopy, actually aerosolizes the patient's what do you call that, upper airway, so the secretions, and this actually helps in the spread of droplets if the patient is infected. Now, if you look at the frontliners who are outside of ICU or who are stationed in other places apart from the intensive care and operating theatre, they are actually in a place where the air actually moves, and in the operation theatre and also in the ICU, air is actually circulated through HEPA filters. Therefore, we have what do you call that? Probably around 60 to 100 times air exchanges, and being at the tip of the spear, I would say the one who intubates, we are actually quite high risk in getting that. It's the same or similar to those taking swabs. So we do wear our PPEs, and I would consider myself as one of the, well, the what do you call that, the speciality is actually one of the highest risks when it comes to this. And yeah, I think that should cover the risk. And if
So
I
tell
would,
me, yeah.
yes.
So tell us a bit more of what happened, maybe in the run-up of how you discovered you had
Right.
been positive, and that
Yeah.
we'll go on
Yeah.
from there.
Okay. Actually, I was very lucky because the symptoms were not really that bad. I was in the operating theatre. We were operating on Saturday and Sunday, and I was in the operating theatre. But I noticed on Saturday I started feeling unwell. Like a viral myalgia, soreness, and then tiredness. I have a mild sore throat. I have a mild temperature. So on Sunday, I was actually still working. And when I came back, I was very tired. But on Monday morning, I was so tired that I actually asked for leave. And then I went to the staff clinic, and I was, as per protocol, because I had symptoms of sore throat and fever at that time, which was low grade, I had to be swabbed. So the swab was taken at 11 o'clock. And surprise, surprise, at 5 o'clock, I got a call from my director asking how I was. And I was like, that was hilarious, because he never asked me how I was. Like, he would be asking, like, where's this report? Where's this data? What is it? When are we doing this? And suddenly I said, yes, I'm fine. I'm actually at home. I just woke up from sleep. And he told me, like, you better wait for a call because we are retesting your swab. So I know already at that time. And surprisingly, they were very efficient. By 7 o'clock, the health department gave me a call. By 9 o'clock, they told me that they are going to fetch me from the house. And then by 11 o'clock, I was already admitted. So my symptoms were very mild at that time. It was just a very slight sore throat. But the most dominant one was actually myalgia and tiredness or lethargy.
Right.
Yeah.
So take us through the next few days, and what was it like to be a doctor in your own hospital?
Okay. Unfortunately, I was not admitted in my own hospital because
Right.
my
Okay.
hospital at that time is not a hybrid hospital yet. We don't take COVID patient. I would have loved to be in my own hospital. Unfortunately, fortunately, I was actually sent to the Hospital Raja Pupa Zainab 2, which is the COVID hospital for Kelantan. So they whisked me off in an ambulance. And what do you call that? and I was admitted into this isolation room. It's about, I think probably 6 or 7 meter by 7 meter long, with a negative pressure. So at that time I was like, well, this is not too bad. I'm not feeling anything, which actually lasted for like, I think 12th or 13th day. And but I really don't like was actually what my friend actually told me. For the last 25 years I've been putting lines to people, and that night they had to put an arterial line, a venous line first, and they took a arterial puncture, and I always get suspicious when junior doctors take my the arterial puncture. Man, that was painful. It was painful, and I was like, I don't know whether I was more terrified than the medical officer, because they were so young, and I compared to me, I was so old. And I think the realization came to me a few hours after I was admitted. They had a patient actually came into the room next door. So me being a doctor, saw that the patient was not doing well. So I was like seeing them resuscitating the patient. And then I was going like, can I help? And then one of the nurses actually turned to me and said, doctor, you must remember, you're a patient now. Therefore, you have to take care. Yeah, and you have to take care of yourself. And I was going like, yeah. And then that hit me. So, and for the next few days, I was trying to help some of the patients, setting lines and things like that. And I find that I can't do it. You know why? Because I had the drip here, so I don't have the dexterity. So I think I was causing more harm. So by the end of the second week, I was going like, no way, I'm not doing anything.
Something for your patient safety note handbook in the future, right?
Yeah, doctors are not
being
supposed.
patients.
Yeah.
So then what happened? How was the development of the COVID illness because it sounds like you were very active for the first few days.
Yeah, I was. Actually, to be exact, it was like 12 days of, boredom, pacing around the room until they actually, I asked them to transfer me out to a multi-bedded, ward. So after 5 days, I think that was on the 6th or 7th day, they actually transferred me to a 3-bedded room. So I was together with my MA and another patient, and we were there, eating, getting our blood samples, and I was not on oxygen. He wasn't not on oxygen. He took a turn where he needed oxygen, so we were doing deep breathing exercises up to I remember it was a Thursday, so they told me that on Friday you're going to be discharged, and I was kind of like, yeah. It's already past my 10th day.
Yes.
Unfortunately, that night I had very high fever.
Right.
I was.
This day 14, just to put that in perspective.
This is on day 14. Yes, and day 14, and I couldn't breathe. It was horrifying because have you had cramps?
Sure. Yes, of course.
Yeah. If anybody has had cramp, imagine your whole chest have the same amount of cramp. It's like, I can't move my chest. I was gasping. I can't breathe.
And that would have been alarming for you as a doctor, especially.
Yeah. I mean, I was like, I'm dying. I better recite the the Shahadah. And I was reciting the Shahadah. I was on oxygen at that time. I have a picture, even though they told me not to take any pictures. Just before the time of actually taking pictures. And what happened? That happened a few times. So, and when that happened, my saturation actually dropped. It was down less than 80 at one time. So being in ICU, I'm and also operating theater, I like to hear the beep, beep, beep. This is now going like beep, beep, tot, 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 tot. That low, what do you call it?
It meant a lot more to you because you, as a doctor, you knew what it signified, right?
Yeah, and I was horrified. And one of the nurses was actually looking at me at that time. I said, "Are you okay, doctor? Are you okay?" And I was like, yeah, that was really scary. That was really scary. And
so take us through what happened next.
So, well, then they sort of like whisked me off to ICU. And one of the things from the ward to ICU, we had to go through the ambulance. So they bundled me into a bed, put the venti mask on me, blast high flow, and then after that send me off to ICU. So I was in the ambulance, and then thank God nothing happened in the ambulance, otherwise I won't be sitting here. And
thank God, yes.
Yeah, and we arrived in ICU. They put me in a room, and I can see them wheeling the ventilator, and I was going like, not that, no, I don't want that. And they took my blood, set lines and things like that, and started me on high flow oxygen first. Did the blood gas. It was not really good because I was saturating like probably around 80, something like that. It was the ABG was going
And
like
you
about.
knew the implications of those numbers as a
Yeah,
frontline.
yeah, that's the worst thing because I can
Right.
really see the saturation. I was kind of like, oh my God, I'm not doing well. So, but I can't breathe, you know? And I was trying to breathe. And they put me on high flow nasal cannula because
Right.
the good thing about this is that the intensivist, I knew the intensivist because he was anesthesia is very close,
Right.
and he said he told me that go on the nasal cannula and keep yourself prone. So for
Right.
7 days I was prone.
Oh, yeah.
Yeah, and that was scary. That was
Yeah.
scary, and that happened in the first 3 days.
Right.
Fortunately, the high flow nasal cannula actually worked because
Right.
why? Because
You never needed to be ventilated ultimately, right?
yeah, because
Thank
I
God.
was so worried because I've read reports about survivability for intubation is actually like
Not
too
good.
high.
Not
Yeah,
good.
yeah,
Yeah.
not so good. So I was really scared of
How
intubation.
long were you in ICU? And as a frontliner, what were some thoughts going through your mind? Because
Yeah.
everyone, well, a majority of the people listening today
Uh,
are your fellow frontliners, maybe not all incentivists or anesthetists, but
mm-mm.
certainly frontliners in different other capacities.
Yeah.
And perhaps you could share with us, from the
Mm.
battlefield, what were some of your thoughts
Yeah.
at that time, and how you came out of it? Because
Uh,
we are here listening and looking at you healthy and smiling. That
mm.
journey is also very important. Tell us.
Yeah. Oh, okay. One thing about health, when you say frontliners, there's so many,
There's so many
it's a
frontlines.
sparent. Yeah, there's so
Yeah.
many frontliners. I think those who work in a hospital know that ICU is not the best place to be. And I think that, just to share, actually, during my time in ICU, I was oblivious to my state, what I was doing. I can see the monitors, I know the numbers are there, but I didn't know a lot of things. And what I can only see was that the doctors, every time they come to my bed, they were frowning. And I was kind of like,
Ah,
that happy hypoxia, like, why are you frowning? I say, I'm playing with my phone. And I was the high flow nasal cannula was my friend. So every time one time it actually ran dry, which we tried to avoid. And this is just an oversight. And I was
right,
going like, because there was the flow was like 50 liter per minute and it was
right.
dry. So it was like fire searing
Painful.
into
Yeah,
my
painful.
nose.
Yeah.
I think that was God's punishment to me.
Oh,
And and I was like, okay, you need to be humidified. High flow nasal cannula cannot be humidified, and I experienced that first time. I mean, personally, and of course, I didn't know how sick I was.
right.
And they told me partly because I was on analgesic infusion, and the
Right.
analgesia actually blunted off. I was like euphoric most of the time,
Okay.
and I have my phone and my what do you call
Happy
that?
hypoxia. Yeah.
Yeah, happy hypoxia. Yeah, it was, and I think it took a few days for my ABGs to be normalized. So one thing is that the information that they gave me did not register. So I
Right.
was like just there, waiting for, a Muslim has got 5 prayers. So I was timing the prayer. So when the prayer was called, and then I would salat, and then I was waiting for the next call, things like that. And
Right.
I was worried about delirium because some of the patient were hallucinating, like, and
Understand.
yeah, and then they were saying like, doctor, don't you see that ghost? And I was kind of like, what ghost? Where? I can't see it, and there were a lot of ghosts in the ICU. I mean, they were hallucinating, and
The
thank God,
hallucinations. That would have been
yeah.
very, very upsetting as well, I'm sure.
In my case, I was like
You're
perplexed,
quite
and I
zen.
was yeah, I was like,
Zen.
where's the ghost? And I can't see it. Why? No, I think because the main reason at that time, because I knew about ICU delirium, so I was keeping time
Time. Okay.
oriented to time. So I have a small window just beside of me, so I know when it is daylight and thing. Because in ICU, the light is always on, it's
That's right.
fluorescent, so that actually plays havoc with
Throws you off.
your
Yeah.
yeah the day night regulation. So I was telling my and the regularity of the solar actually helped. And
Oh, good.
yeah,
Some tips
nearly,
on how to deal with it.
yeah, when you're like can't breathe, you don't have much time. So you make preparations, and going back to religion is one of the things that
Right.
I find that.
That's an interesting perspective.
Yeah, and because when we work, we were so like rushing for time. And there in when I was admitted for 23 days, I've got time. Essentially, I'm not rushing
So
anywhere. I was
23 days altogether.
yeah, altogether 23 days. So there was a
When did
lot
it
of reflection.
turn? When did it turn from the ICU? How many days were you in ICU, and when did you start to see
Ah.
a turn in your progress?
Right. I started improving, I think, after day 3. By day 4,
Day
I
3.
was actually on nasal prong, and they actually took away my best friend, the high flow nasal cannula, and I was kind of like, can I keep that? You know.
But that was 3 days of must have been quite stressful on a certain level if you were being observant about what could be happening because you were not breathing. So that must have been 3 high tension days on some level.
Yeah.
And it sounds like you used your faith to keep yourself going, apart from being entertained by stories from the other patients as well. But yes, so tell us more. Yeah. So
okay. So the other thing you mentioned, it was really stressful. I mean, but when I was prone, I can only see the front of me, which is actually a bank of switches. If I was supine, I can see the ceiling, and I had to turn my head to go and see the patient. And turning with the high flow nasal cannula is not really
not
that
easy,
good. Yeah, but I really hated the alarm monitors. You know, like they told us that we have alarm fatigue when we were working. Yes, if you're on the other side of the bed, you tune out the alarm, but you're on the bed, you can hear that and then after that it's like a chorus, and then the infusers will start and the other patient will like so like there were like 4
this is an interesting perspective that you're going to be taking when you think of all your patient safety and patient protocols, because now you've had a chance to be on the other side of the battlefield as such, right?
The bed, yeah.
So that's a valuable takeaway. And so moving forward, the recovery, tell us a little bit more about the recovery, because 23 days it turned, and then I mean, those of us at MLSM, you've been so generous to share about your recovery. If I may invite you to share a little bit about your recovery with the audience today.
Yeah. Well, after like 3 days, then I improved. So and then they told me that they needed a bed. So which means that I get to go back to the what they call normal ward. So inside the normal ward, I was very active. I was prone. I was exercising. I was doing the deep breathing exercises, and that really helped. And eating, of course. But the problem was that the food was tasteless. So they always say that hospital food is bad. In my case, I didn't experience it because I can't taste it. So Food Panda was my friend during the recovery period, and while I was doing inside there, they don't allow me to exercise because the lung was still inflamed.
Sure.
So I was walking around. So when they told me on the 23rd day that you're being discharged, I was like, hey. And then I said, okay, they packed up my bag and they bring my bag, and then they wanted to wheel me out on a wheelchair, and I told them, nope, not happening. So I'm going to walk myself out. I probably get to the front of the ward. I was actually like, and then by the time I reached the car, I couldn't even leave the bag. And I find that one of the things that they said, because I couldn't believe it, with this disease, it affects your effort tolerance. Because the lung, even though the lung is recovering, the effort tolerance is still down there. So I had my CT scan on the 4th week, and the lung function test on the 6th week. Both are normal, but I still have that symptoms and things like that. And
even now, months later, are you having some residual recovery elements? That's valuable, I think, to know for everyone as well.
Yeah. And I had a lot of my colleagues, not a lot, I mean, some of my colleagues that was admitted who had similar results. It can last for about 6 months. Tiredness, post-viral, essentially tiredness, breathlessness, and things like that. And my sleep is still not, what do you call that, as it used to be.
Yet.
So a few hours of sleep, and then after that we wake up and things like that. So but the most important thing, I think, the way I look at it is that I was focused on recovery. I wasn't thinking about complication and things like that. So, get over this,
so
get back to work.
The positive flip to that.
And that helped me, plus the WhatsApp messages and technology, what do you call that? Noise cancelling, what do you call that? AirPods, that really helps.
Noise cancelling AirPods. Good to know.
Yeah.
Dr. Ariffin, we've got a question from one of our audience. Because, based on your story, you deteriorated after day 14 of your illness. And, at that time, your medical advisors had said that you actually were in preparation for discharge. And right now, I think in the country, some hospitals may be discharging patients at day 10 after diagnosis. So perhaps something to share with your colleagues who are listening in. What are some of your thoughts about discharging patients at day 10? What are some of the precautions that can be told to patients so that they're not alarmed and suddenly think that, there was medical negligence or something which will, worry the rakyat in terms of your experience. What are your thoughts about this?
Okay. I have to tell you, Shanti, that I'm unique because the
You are
deterioration.
definitely unique.
Okay.
Let's not dispute that.
Okay. The reason for the day 12 deterioration is not because of the COVID virus. It was
I
actually the
see.
cytokine release storm. So I had cytokine
Cytokine
storm.
release storm. I
Yes.
see.
So
So you
it
had
was.
one of the rare reactions.
Yes, I had the rare reactions because I've always, unfortunately, I always had this problem with hypersensitivity. And one of one of my colleagues told me, give an analogy. You don't get killed by the earthquake, but you get killed because the building actually topples on you. So he was referring to my immune system. So what happened to me was that on the day 12, I had a cytokine release syndrome relapse, and that was really bad because my body was actually turning against me. So that actually inflamed my lungs, my liver, my pancreas, and also to a certain extent I had a pancreatitis. So looking at the protocols, discharging the patients at day 10 or less than day 10 after the COVID, initial period is not against anything. I mean, it is it follows protocols, and it is the right way to do it. But we have to explain to our patients that if they have any deterioration, for example, high fever, inability to breathe, or they have inflammation, pain, like in my case, it was a interscapular and retrosternal pain because of the pancreatitis, they have to come back to the hospital, or at least we need to monitor them and tell them that these are the things that you have to be on the lookout for. And
Awareness.
Awareness, education is very important to look out for this. But because it's rare, it will not happen to many patients. Like I'm probably 0.001% of the patient. So if you ask me about whether it is appropriate to discharge earlier, I would say yes. 23 days in hospital is horrible. Like to be cooked up in an isolation ward. If and just to share with you, in our cluster, there were 27 patients. I was the only one that had that.
I see.
Yeah, only 3 of us were admitted into ICU. One died because of complications from the heart. Actually, was a problem, and the other guy was extubated well. So some of these patients have got complications like stroke and things like that. So these are the things to be looked out for, rather than because it's not only the virus that causes the problem. The body reaction to the virus also causes it.
Absolutely.
Yeah.
Thank you so much, Dr. Ariffin. And I
You're
want to just
welcome.
end this on an upbeat note, because I think anyone observing you can see your positive nature, and I think I want to leave you with ask you to leave us all with a thought. How does one remain positive when diagnosed with COVID-19 positive?
I think the discussion yesterday, how to be positive, COVID positive, I think the reflection is one thing. Reflect the good things, like reach out to people, and I'm very fortunate because I'm the team that was caring for me is actually, we belong to a small community, therefore we were knowing to each other, we know each other and things like that. And if I were to sort of roll over and die, they probably will be saying like, so that actually sort of like spurs me to continue. Yeah.
I just read your CV.
Yeah, I can't afford to do that because
No.
people are looking up to me, I guess. The other thing is actually my family and my colleagues, my team, they were very supportive. I mean, COVID is not just a physical illness. Well, majority of the patients who are actually from my unit actually have got psychological problems, like stigmas and things like that, and then they needed support. And the psychological support was quite strong because we have a psychological first aid kit, and this actually helped. And the psychology part actually helped, to keep focus, knowing what coping mechanisms to actually put in. We were taught on deep breathing and things like that. And the psychiatrists and the psychologists always at least twice a day will be calling us.
Oh, so that's fantastic. So it's a holistic treatment, not just the
Yes.
physical, but also the psychological and the emotional. So, I think that's a good frame to leave our audience with, because at the end of the day, you need to battle this on many fronts, not just the physical, but the psychological and emotional one. And preparing those tools in advance, because we are still facing this particular scourge, and this battlefield is open and out there. Thank you so much, Dr. Ariffin, for what
You're
you've
welcome.
shared. The generosity is truly appreciated, and I'm sure our audience will take something very valuable away from this. Now, but thank you all very much. Thank you very much. And we're going to now move on to someone else who is in the front line, the eye of the storm. To introduce our next speaker will be our Honorary Secretary, Jason Lau. You will be introducing our next speaker. And I'd like to thank you very much, Dr. Ariffin, again. Thank you very
You're
much.
welcome, Shanti.
Take care.
Okay,
On
bye.
to you, Jason.
Thank you, Shanti, and good afternoon, everyone. My name is Jason Low. I am the Secretary of MLSM, and according to our speaker for this session, I'm also the Society's vaccinated baby face. And that makes me qualified to be the moderator of this upcoming session, Challenges Delivering Babies During the COVID-19 Pandemic. Now, we all know what happened in March 2020. The two major things that happened. First, MCO 1.0 was implemented, and most of us have to stay at home with our loved one with almost nothing to do. Another thing that happened during March 2020, there has been a shortage of rubber supplies in Malaysia. So if you put 2 and 2 together, you would have thought that the numbers of babies and pregnancies are rising, but apparently that's not the case, and our speaker will explain why. Now, to our speaker, let me introduce our speaker, Dr. Siti Rohayu Baharain. She is a consultant obstetrician and gynecologist and a medical director of her own maternity center in Sungai Petani. She is also an EXCO member of MLSM, and she is one of the loveliest, charmingest, and most confident doctor that I've spoke to in a very long time. She moderated in one of our previous events, and the way she spoke, the charm and her eloquence simply put all of us in awe. Without further ado, I introduce you, Dr. Siti Rohayu.
Right. Thank you very much, Jason, for that awesome introduction. And yes, having shaved, you do have a beautiful baby face, baby-looking face, and yep. It makes me smile and laugh, relating your introduction to what I'm going to be speaking about. So I'd like to actually share the screen because I've got a few slides prepared. So hopefully we'll benefit from this short experience sharing. Okay. Right. Just bear with me, yeah. There we go. Okay, I think everybody can see my screen right now. So I'm just going to be talking about an experience delivering babies during
Dr. Siti, I don't think your slides are up and running at the moment.
Oh, I see. Right. Yeah, wait a minute, just a moment, yeah. Gosh, I'm from the last generation, not Jason's generation. So yes, let me just get that right. Bear with me a moment. Sorry, everyone. Share screen, PowerPoint.
There you go.
Yes. Okay.
Yes, you did it. Yay.
Not so bad, isn't it? Okay. So yes, I'm going to share about challenges delivering babies during the COVID pandemic, and there's a picture of me holding a pair of twins who I delivered just before the MCO. So just as Jason mentioned just now, I'm a consultant obstetrician and gynecologist and medical director of a small maternity hospital in Sungai Petani. And this is a picture of my hospital. It's called Wisma Pakar Perbidanan and Sakit Puan Sungai Petani. Our capacity is 15 beds at the maximum, and we have 3 labor rooms and 1 full-fledged operation room. We mainly do low risk obstetrics, and we do gynecology cases occasionally. Right, so Jason, basically when we start to talk about the COVID pandemic, I think I'm going to start by saying that when the government announced the first MCO, we honestly thought being up north in Sungai Petani in a sort of like kampung area, it's not probably going to affect us so soon. It probably come to us a bit later, probably a month or so after the announcement. But we were so wrong, by thinking of it being like that. So what happened was, following the announcement on the 18th, we actually came in contact with a patient 2 days, barely 2 days into that announcement. And this patient actually came to us to have a checkup for her baby. We call it a CTG or cardiotocogram that we use to monitor the baby's heart rate and also if there were any contractions present. So she came at 5 a.m. We did that, and after that, due to some underlying circumstances, she went to a different hospital for delivery. Excuse the doorbell, someone decides to come at this moment. Anyway, so following that, what happened was after a few days, we got note that this patient was actually affected by COVID. And because she wasn't very upright, straightforward about being infected, and the fact that her parents actually came back from the public meeting and were already tested positive, sparked a rage among many of us, especially myself and my staff who attended to her. There were about 5 staff attending to her that morning, and all 5 had to be quarantined. And this had led to really low morale among us in the hospital following that exposure. So, sorry? Yeah.
Did you have to close down your center?
Fortunately, we did not have to close down, because when they came for inspection and a risk stratification, we were deemed to be low risk of infection. So we only needed to clean up the labor room that was used for the CTG, and later 5 of our staff, including a consultant, had to be quarantined, and that was bad. So if you can see here, I'm holding up this banner here saying, I stay at work for you, please be honest to me. And this was because at that time there was this thing going on in social media saying, I stay at work for you, you stay at home for me. But it was totally a different situation for me, because being lied to in the face of such a deadly virus was something that was very difficult for all of us to accept so early into the MCO. So yeah.
And I see that you got viral. You got reported on Malaysia Kini and this Chinese news.
Yeah, viral. It's okay to be viral, but not COVID viral. Right? Yes.
Yes.
Right. Yeah.
So, doctor, how do you re-emerge after this initial scare?
Well, to say re-emerge, yeah, that's probably the right word to use. Yeah. What happened was, I took some time to tell myself that this can't go on, we're healthcare workers. We can't be hiding in our shells and all that. And someone fortunately sent to me this diagram, this circle diagram. I think a lot of you all may have seen it and could relate to it. So who do I want to be during COVID-19? And I realized that at the moment I was in the fear zone. But the faster I could get out of the fear zone into the learning zone and ultimately into the growth zone, the faster it would be for my staff to adapt, the faster it would be for my patients to accept us, and the faster it would be for us to be back on our feet and running. So I started planning strategies to tackle this issue.
Right, and I believe that involves motivating your colleagues.
Absolutely, absolutely. So our attack plan was actually in 3 main areas. The first one was motivate staff daily. My staff, I think there are a few of my patients in the audience, and I think most of them probably agree that my staff are like a big family. We're a big family, we work together. In difficult times, we do away with ranks, So what we did was every morning we'll have a roll call in the labor room. And during the roll call, what would happen is we just sit down, forget that, I'm the boss, you're the sister, you're the junior. Everybody come together and talk about what it is that makes you really scared. The threats of the virus. How was it that how are you being affected by it? Are you having any difficulties with regards to people surrounding you? Are there any restrictions to travel for you to come to work and all that? So we tried to support each other in any way we could, and doing that actually made us stronger together. And I could see that my staff were more prepared to fight the coming virus rather than hide themselves in the shell. So that was something that was really beneficial.
That's great. How about your patients? How did you give them a reassurance that they need?
Antenatal patients, I think everybody knows, is a unique group of patients, because you can't really let them not come for follow-up for 1 month or 2 months until the MCO is lifted or whatsoever. So what we did was we laid out all the patients that required to come for follow-up, and we started calling them up one by one just to listen to what they were facing. What were their fears? Were they going to come? Were they making plans to come? Did they need any letters to cross borders and all that? And we changed our clinic system altogether. It may be normal for many clinics to have an appointment-based system, but in a kampong, I'm going to say kampong for Sungai Petani style, yeah, to have an appointment is something not normally practiced. So somehow we had to start doing appointment-based follow-ups only. So that markedly reduced waiting time, and it allowed us to implement physical distancing, and it gave the patients actually less time in the clinic. Some ladies were actually very scared to come out even to go to the hospital. So that also worked, and to further make that work, we actually offered the patients an incentive. We gave them a 30% discount on their clinic visits every time they came on time at the right date and fulfill their appointments, which was a major hit with many of the patients.
Right.
Yep.
And I see that you're utilizing social media to keep in touch with your patients as well.
Yeah, well, social media is a miracle. I mean, I think it's a good thing that during the pandemic, we have access to social media. So before COVID came, our Facebook page was, what Malays would say, hidup segan mati tak mau. It's like there, not there. So we started to boost up our posts. We posted information about COVID, precautions, things on ONG topics, and we shared pictures with patients' permission, of course, of patients who successfully delivered in our center during the storm. And it actually pushed up our audience, interactive audience. I didn't buy any followers, yeah. We're at 12,000 right now. And apart from that, I was forced to do live Facebook sessions where I would talk about a certain ONG subject every week. And this is to replace, the chatting that I would have with all the patients in the luxury of time before COVID. And one of the talks on diabetes in pregnancy actually hit the 25,000 mark view, which for me was something very new, unexpected, really.
Well, what they say about this, sharing is caring, especially on information in this age of misinformation.
Absolutely, absolutely, Jason. Yeah.
Yep. And by which time, by the second half of 2020, following the implementation of the CMCO and following the RMCO, the numbers started falling.
Yep.
But after that, I understand that there is a sudden spike again in numbers, especially in the state of Kedah.
That's very true, Jason. So I'm going to name this spike as Battle Round 2 for us, because, after Raya Haji and all that, there was suddenly an emergence of new clusters in Kedah. I think people would never forget the Siva Ganga super spreader cluster. It wasn't directly coming to Sungai Petani, but then we started having all this Tawa cluster and Bah clusters after the Pilihan Raya in Sabah. And there were also some sporadic cases in the community. So this was another round of scare for us, because we thought that we were up and running and the virus was far away from us again. But we realized that it was nearer than we thought. So at this point, we had no choice but to reinforce further our fort, and we did that by mandating PCR testing for all our patients and husbands who wanted to accompany wives into the labor room.
Right. Were the patients cooperative, or did they find it more as a hassle?
Well, initially, because PCR testing is not something that's very cheap. So there was a lot of resistance. It's not so much of the hassle, I would think. It's more of the cost. We managed to get it at a private lab for 240 per person. So, for 2 persons, it's an additional 500 ringgit cost. And the inconvenience of having to go to the private lab for screening and all that. So there was initial resistance, but after a careful discussion and explanation, I would happily say that now all of our patients in the ward and in the labor room are PCR tested before any further treatment from us.
That's great. That's great. Well, earlier this year, the Yang di-Pertuan Agong declared a state of emergency, and the government actually came up with this emergency ordinance 2021. Does it affect your maternity center?
That's a good question, Jason. With regards to the powers under the ordinance of the Emergency Act, provision 4, demand for use of resources. I think there was sort of like a tsunami sometime last month with regards to, the surging number of COVID cases and the need for private centers to help out with COVID patients. So I remembered with this regard going to Alustar, there were many rounds of meeting with the Jabatan Kesihatan Negeri, which was really, really informative. It helped me understand and, see the situation from ground zero. But because we were a single discipline hospital, we did not have separate access for COVID positive patients. We do not have ICU backup. We do not have skilled staff to nurse infective cases and all that. We were finally not gazetted as a hybrid hospital. So yes, we were not forced to take care of COVID patients up till now.
Right. So, Doctor, do you foresee any future challenges that is brought by the pandemic, especially in the ONG specialty?
I think not only in the ONG, challenges I think will affect everyone. It's like a ripple in a pool, the small ripple starts and everybody will get affected. And what I mean by this is there has been a reduction in the birth trends during the pandemic, as demonstrated by the Department of Statistics Malaysia. So if we make a comparison between the delivery numbers in July to September of 2019, as compared to July to September in 2020, the number of births actually dropped by 5.9%. And there is a lot of prediction that the number of births will continue to drop beyond that. And I foresee that this is compounded by many factors, and among the greatest would be loss of income or reduction in economic potential of citizens, delays in getting married and having children, same because of the economic issue. I do see nowadays increasing requests for contraception, and there seems to be reduced government funding for infertility treatment, as it is deemed as non-essential at the moment. And there have been patients who are actually worried about long-term COVID infection in future children because it's still a very new disease and there's so much that we don't know about it.
And how does this reduction in birth rates affect the society in general?
Well, with regards to that, I'd like to quote Datuk Dr. Amar Singh in his previous sharing during our Speaking for the Unspoken, which he mentioned about a lost generation. A lost generation is something that happens after a major catastrophe, for example, a war. So a lost generation would mean that there's not going to be a big number of births during a certain period of time. And this will cause a loss in the sense of education, working terms and manpower, and also there will be two staggered populations at the far ends. So this would be an issue that the government would have to seriously start to look into before this lost generation actually materializes.
Now, Doctor,
yeah,
the most important question, is there still hope?
Of course, there's hope, Jason. If we have a look at this slide here, if you can see that's a high five. Yeah? That's a high five from a female twin of a fraternal pair of twins conceived during the COVID storm, and she's just saying, just definitely hope. See, high five here for hope, yeah? And I'd like to share here that this is fresh from the oven. This is guidelines on COVID vaccination in obstetrics and gynecology, version 1, by the Ministry of Health Malaysia, that has just been rolled out very recently on the 14th of February. That's about a week ago. So catching up with all this vaccine excitement, there's a lot of excitement about the vaccine and arrival of vaccine. So obstetrics and gynecology, obviously we do not want to be left behind in this excitement. And I'd like to just like read key recommendations number 4, 5, and 6 with regards to the vaccination, because they have done, I mean, you know, virology principles have suggested that mRNA vaccines are safe in pregnancy and breastfeeding. And these vaccines, number 5 would say that these vaccines actually have a major role in protecting pregnant mothers who are at an increased risk and are more vulnerable in the event they were to be infected by COVID-19. And as key recommendation number 6 recommends, women who are actually planning to get pregnant should get COVID-19 vaccination before they do. There are other recommendations, but I think this is the most relevant for us at the moment.
Right.
Yeah.
So, Doctor,
yeah.
what is your greatest fear when handling a pregnant patient in this pandemic?
I think when we talk about fear, I have a lot of fears actually, fear of the unknown. But to date, my biggest fear is that if a patient who I have, you know, been following up and cared for so much during the pregnancy suddenly becomes infected by COVID-19. And unfortunately, that happened quite recently, about 2 weeks ago, where a patient who was scheduled for a cesarean section in the near few days actually got infected by COVID-19 from her husband, who came back from outstation, and the whole family was hospitalized. And she has, however, successfully undergone a cesarean section to receive her first baby, and they're doing well. But, you know, COVID, as Dr. Ariffin mentioned, can affect you in so many ways. So I still have that fear of, you know, a pregnant patient getting infected by COVID.
And I suppose it will have a greater impact on the pregnant mother, especially her mental well-being. How did the pandemic affect the mental well-being of an expectant mother in general?
Expectant mothers are actually a unique group of people. You know, with pregnancy itself, there comes a lot of anxiety, there comes a lot of hope, there comes a lot of uncertainty, and add COVID on top of that. So it's further exaggerated. So I think as people caring for pregnant mothers, the most important thing that we would need to do in this time is to try and keep ourselves updated and try and dissolve whatever uncertainty, whatever fears these mothers have with regards to, you know, delivering and getting pregnant during this COVID storm.
And I trust ONG specialists like yourself will have an important role to play in it.
I hope so. I hope they regard me as an important role. Yeah.
No, it's great to. It's actually quite encouraging to see that you, after the virus dealt the first blow, you got back on your feet so quickly. And I believe there's a lot of doctors who are in the audience listening. They may appreciate a pointer from you on how to, you know, get back and get going. Do you have any takeaway message for our medical practitioners?
For my colleagues, my beloved medical colleagues, I would just say that, you know, when we stepped into this profession, we only want to do one thing, which is take care and help patients get back to health in any way possible, regardless of what surrounds us, whether it's a natural disaster, whether it's a pandemic, whether it's a war. And we do that knowing that, you know, it puts us in danger, but, you know, we have to take care of them and ourselves. And in this unique situation, one word that I would not forget to say is adaptation. The faster we adapt to these changes, these challenges, the faster we are able to collect our strength and move forward to better serve our patients. So I think that's what I'd like to leave for my medical colleagues.
Right. Do you have any takeaway message for expectant mothers?
And for my beloved mothers, the only thing is, you know, pregnancy is a beautiful journey, and there's a lot of hope when it comes to pregnancy. And we will try our best to continue to care for you, update ourselves to make sure that we can give you the best. And do come back to us if you have any doubts, you need clarification, because, you know, pregnancy during this time needs more input, more support than ever before.
Right. Thank you, Dr. Siti, for putting a positive light to all this in the midst of a pandemic.
Thank you. I just like to share the final quote and this beautiful picture of my patient, of course, with permission, admiring their new baby. Puan Fatin and Encik Muiz admiring their new baby Uwais, who was born during the storm. And like it says, a new baby is like the beginning of all things, wonder, hope, and a beginning of new possibilities. Thank you very much.
Thank you, Dr. Siti. Now we have one question from the floor. Now that the vaccine is rolled out, what would you advise a pregnant and breastfeeding mothers?
Right. The vaccines are very new, but in keeping with the guidelines just now rolled out by the Kementerian Kesihatan, they said that the mRNA vaccines are safe for pregnant mothers and breastfeeding ladies. So I think it's probably best that we continue following what the recommendations are according to that guideline.
And also as well as in providing information and educating the public is very important in this aspect.
Absolutely, yes, yeah.
So if we do not have any other further questions from the ground, then thank you, Dr. Siti.
Thank you, baby.
Fantastic,
Jason,
fantastic session. Thank you so much.
Thank you very much. Thank you.
Oh, we have one from Dr. Ariffin. Thank you, everyone from. Oh, I don't think that's meant for you. I'm sorry.
No problems. No problems.
Sorry for the hiccups. Now I pass the session to our next moderator. He is the Honorary Treasurer of MLSM. May I present Dr. Mohktar. Over to you, Dr. Mark.
Thanks, Jason. So good afternoon, everyone. My name is Mark, and as Jason mentioned, I'm the Honorary Treasurer of the MLSM. Before we start this session, I'd just like to highlight to everyone listening and viewing that there is actually a Q&A function at the bottom. And so if there are any questions that you have with regards to our next presentation, you're very welcome to type in your questions there, and I will then read it out to our speaker at the end. All right, so facing uncertainties is certainly something that we have had to accept during this pandemic. And for those of us who have been following, the events that have been unfolding in the past year, we'll realize that frontliners and healthcare systems have had to make unprecedented decisions. Although in Malaysia, we've not had to face a COVID-19 hurricane or tornado as such, that was experienced in Italy and Spain and America. We've certainly had to ride, the waves of a COVID-19 storm here in Malaysia, and also to face, similar ethical decisions that have had to be made during this time. So it's my pleasure and my privilege to introduce to you our next speaker, who's a good friend, a mentor, and a close collaborator of mine, Dato Dr. Patrick Tan Seow Koon. He's a consultant in anesthesia and intensive care at the University Malaya Specialist Center, and is a member of the MLSM, as well as the Malaysian bioethics community. Before this, he was previously the professor at the University of Malaya Faculty of Medicine, and has co-authored a few chapters in the book Bioethics and COVID-19 Guidance for Clinicians, including chapters such as triaging protocols for ICU admissions, beds, ventilators during resource crisis, and navigating through challenges in clinical practice during COVID-19. So today, Dr. Patrick will be helping us to navigate the COVID-19 storm, speaking to us on ethical issues which arise in COVID-19 treatment. Over to you, Dr. Patrick.
Thank you very much. Would it be possible to start the video from the host end?
Yes, let's see what we can do with that.
Are you able to see anything on your screen?
Yes, right now I see your cover slide.
All right, that's excellent. Good afternoon, everyone. Thank you, Medico-Legal Society of Malaysia, for your very kind invitation. And thank you, Mark, for your very kind introduction. I have no conflicts of interest to disclose. If I may borrow Hollywood imagery, the COVID-19 pandemic caused by the SARS-CoV-2 virus is Star Wars on Earth, real time, in every country. It is depicted by opposing tensions of duress. On the one, a global assault on humans, involvement of personal tragedies, bringing turmoil, loss of momentum and justification across vast social and economic systems. Challenged by a defensive front, we shall call these members primary responders, healthcare providers and systems which support efforts to contain and suppress the COVID-19 pandemic. These groups under duress and the defenders are not mutually exclusive, as we have already heard from the first speaker. COVID-19 is no respecter of human ethics or rights. The title, Ethical Issues in the Treatment of COVID-19, covers many areas which can be described at great length. In the time available in this talk, I shall elaborate on 5 issues which impact on infected persons, the public, and the healthcare provider, explaining these issues through an ethics filter because in this existential reality, when the threat of SARS-CoV-2 human virus infection is finally settled, the COVID-19 pandemic has been fought on the principle that human values of charity and compassion for threatened lives is the most meaningful justification. The ethics issues I wish to highlight when discussing COVID-19 treatment are autonomy versus justice, balancing individual and societal needs and rights, achieving fairness in resource allocation, and on triage, when decisions affecting lives have to be made by impartial rules called triage based on human data and statistical reasoning. The need to include ethics in the conversation on triage is very necessary because it also serves justice. 4, to deliver ethical behavior, especially at the end of life, in compassionate care, and the reality in many places of a maldistribution of this standard. And lastly, the human existential cost of healthcare provider disintegration. In other words, what happens when the primary defender is defeated? The first one is autonomy and justice. We know that respect for an individual autonomy is one of the 4 foundational principles of medical ethics. It's enshrined in a doctor's duty to care, acknowledging the right of a person to give or withhold their consent to a doctor for any decision with medical and life impact. A doctor defends this principle to the utmost, using all their expertise and calling for help from other doctors to do their best to serve the wishes of that person. A doctor's respect for and duty to an individual is balanced by another foundational principle of medical ethics, delivering justice for the common good or delivering healthcare to the greatest number according to available resources. In the last 12 months, our vocabulary has expanded with new descriptions such as personal medicine versus public health medicine. While they may be a form of rebranding, we have to keep our ears close to the ground to hear whether pandemic ethics, another new term, is moving society towards a different standard of care that is, shall we say, predominantly utilitarian, and which carries the implications for the balance, the delicate balance between the individual rights and society. In the context of the COVID-19 pandemic, members of the society may have perceived or been influenced into believing that individual autonomy is more important than societal justice. This is seen in the public response to wearing masks and expected in the rollout of SARS-CoV-2 vaccination. There may be an under-realization that an effective herd immunity and end to COVID-19 pandemic might not be achieved if the percentage of total population worldwide who are vaccinated is less than 70%. Hence, supremacy in the rights of autonomy has an impact on serving justice. Fairness in resource allocation. By a global achievement scale, Malaysia's public health system stands tall. There is uniform coverage of community health monitoring in clinic kesihatan, school health, nutrition, immunization, maternal health, dental health, and other services. Secondary and tertiary healthcare resources are concentrated in cities and large towns. It may be relatively difficult for rural populations to have similar access. An infographic on the odds of death from COVID-19 by age group shown here based on US data up to January the 20th this year may not reflect the situation in Malaysia when affected by differences in the distribution of healthcare resources across the country. But we must also be aware of differences that exist between populations of patients, such as those with COVID and those without COVID. And there are issues in vaccine allocation which also fall into this category, but I will not be discussing this in this talk. Now, this is a busy slide. It'll take a little bit of time to explain. In triage and justice, there must always be room for consensus-targeted ethics conversations. Triage may be applied when resources are finite and the capacity to treat all illnesses may be exceeded or overwhelmed. For example, we saw what happened in other countries such as Europe and the UK and the US over the last few months. When this happens, it may be necessary to do a head count and to do the severity of illness count on all these patients in order to give more statistical reasoning of the chances of survival. This has been done over at least 40 years and has been validated statistically. And the severity of illness measured by these biologic scores, such as blood pressure or oxygen level and kidney function, can be amalgamated into a single score called the Sequential Organ Failure Analysis, or SOFA, S-O-F-A, which is just an idea of the number of organ failures, such as heart, lung, kidney, liver, bone marrow, and so on, together with the weightage due to increasing physical age. And they have been found to be robust predictors of the chances of death or survival in any patient situation. And healthcare system providers can be authorized to apply predictors to allocate resources to those with a greater chance of survival, such as in the guidelines on intensive care, which have been published and are available through the Ministry of Health and the Malaysian Society of Intensive Care. Patients and families are likely to understand and accept if the correct explanations are given at the time. And the decision steps and the communication to patients and families must be justly applied in an inclusive philosophy. Ethics serves justice. This table just illustrates the SOFA score and is used in deriving a survival likely score or a death likely score for each individual patient. And we have seen in recent publications such as this one from the Annals of Intensive Care that there are very serious ethical concerns on triage and withdrawal of life support, as well as concerns that we may not be achieving the provision of the quality of end-of-life support. And these together can lead to a lot of distress situations in major caregivers, leading them to experience sufferings and feelings of depression and so forth, which have to be addressed. There has also been an imbalance between the utilitarian and the individual ethics, as I said earlier, which leads to unsolvable discomforts that caregivers will need to overcome in the future. So delivering compassionate end-of-life care is not only very important, but it has to be equitably distributed. And there is a reality of a maldistribution of this standard. There are some ways in which we can address this. A small Malaysian bioethics community was formed by a group of doctors and lawyers and other scientists and other interested ethicists in the first quarter of 2020, and has been very active in meeting together and discussing many of these problems, as well as delivering talks and webinars in order to share our common concerns and in order to drive a way forward, in order to help our people with COVID as well as the caregivers. And we also have Clinical Ethics Malaysia, which is a very private forum to which anyone can write into with a particular clinical problem, and these problems can be discussed very confidentially and then disclosed to the person who has written in. So you are encouraged to write into these forum if you need any particular ethics question on COVID or any other particular treatment to be made. My fifth point that I wish to talk about is that it has been very apparent during the treatment of the COVID pandemic in every country that healthcare givers, the primary responders, have been facing moral distress and exhaustion and compassion, fatigue, as well as burnout and illness from having to deal with a non-stop effort to be the primary defender. This raises the question as to what will happen when the primary defender is defeated. And my last question is, what framework can be applied to achieve a meaningful response from society? There are no concrete examples of responses to this scenario. The debate is embarking, and I think this is a good time for me to pause here and thank everyone for listening and look forward to our subsequent discussion. Thank you very much.
Thank you very much, Dr. Patrick, for that very enlightening talk. I think we have one question in the Q&A box, and I shall read this out. During the pandemic, doctors from other departments were asked to care for COVID patients. These doctors were not trained in infectious disease. How will insurance cover these doctors if anything goes wrong?
I think that this is a very real question faced by many of the health providers. Excuse me. There are two ways in which we can be better prepared for this. The first is that the institution can provide the necessary support to equip the doctors, not just with physical protective equipment, but also in the training that is necessary to be able to respond primarily to this particular group of patients. That is to say, we have to go through training procedures to equip and to help and to support these doctors to do their job. It's a very necessary task. It's a war zone, and I think if we can agree to go forward together with the necessary help. That is one way of doing it. And the second way is to say that, well, I'm a doctor, I have a medical degree, I have been trained once upon a time as an all-rounder, and I will be prepared to dust off my previous learnings and reacquire them and be supported effectively by my colleagues in journeying forward. I hope that answers.
Thanks, Dr. Patrick. I don't see any other questions in the Q&A box, but I do have one which I'm hoping to get your opinion on, and it has to do with we've been talking about COVID-19 and the ethical issues with COVID patients, but in reality there are also non-COVID patients who have suffered as a result of this pandemic, patients with other illnesses who have not got treatment. So, could I get your comment on, whether, what sorts of ethical issues are faced from that aspect?
Yes, primarily, I think you're quite right that you're moving further back of the queue now in terms of being prioritized for your own care. And that is in a way that is a maldistribution of justice. We do the best we can. And I think that every government will try to acknowledge that there are priorities in catering for everyone. So our own Ministry of Health has also been, it's not shut off services completely, but it's what's the word for it? Relocated them to other centers to carry on as best as possible. So I think there is an acknowledgement that these are difficult times and everyone shares the burden a little bit more, but we're doing the best we can.
Okay, all right. So thank you very much, Dr. Patrick, for that superb talk and that allusion to Star Wars. I think we all loved that allusion very much. So now I'm going to hand the next session over to our next moderator, who is none other than the President of the Medico-Legal Society of Malaysia himself, Dato Dr. Venugopal. Over to you, Dato.
Thank you very much, Mark. For all of you who have tuned in, great appreciation from the Medico-Legal Society of Malaysia, MLSM. This is MLSM's first event for 2021. And COVID-19 comes with a lot of negative connotations. But we at MLSM, we thought we would start the year on a positive note. Now, Ariffin is a very dear friend of ours, friend of mine. We have operated together so many times in IJN. And when he was navigating the COVID storm, we were all very devastated. But he came out of it full of life and smiling and happy, as you saw him in the first talk. And we thought that there would be no better person to start off today than Ariffin. Now, babies, I think, are all about the innocence and joy of life. And we thought that, okay, so Ariffin is doing well. Now let Siti talk about babies. And she has done a wonderful job, though the blatant chemistry between Siti and Jason came as an unexpected bonus for us. Then we thought we'll ask the hard questions and the hard facts. And I think Dr. Patrick Tan has so elegantly and very eloquently highlighted 5 major ethical issues that we need to grapple with. And now comes the icing on the cake. And it is with great pleasure that I'm very happy to announce that we have with us today Emeritus Professor Dato Dr. Haji Shad Saleem Faruqi, who is the voice of the Constitution of Malaysia to give us his thoughts on the emergency, the COVID, and the Constitution. Now, ladies and gentlemen, Prof. Shad is the 4th holder of the Tun Husainon Chair in International Studies at the Institute of Strategic and International Studies, ISIS Malaysia, for the period July 2019 to June 2021. Prof. Shad is also currently the holder of the Tunku Abdul Rahman Chair at the Faculty of Law, University of Malaya. He holds so many other distinguished appointments. He is also the author of 10 books, including Document of Destiny, the Constitution of the Federation of Malaysia, Reflections on Life and the Law, Media Law and Regulations in Malaysia, which I hope Malaysia Kini serializes it, and of course, our Constitution. Now, in 4.5 decades in the law, Prof. Shad has authored more than 600 articles in journals, periodicals, and newspapers. He has done many national and international consultancies, including the drafting of the Constitution of the Republic of Maldives in 1992. I had the pleasure today of getting to see the personal side of this gentleman, whom I picked up from his house before this event. And in the 20 minutes in the car, I realized that he is an epitome of humility, which I think is the hallmark of any gentleman. And ladies and gentlemen, now let us have Prof. Shad Faruqi to give you his thoughts on the emergency, the COVID, and the Constitution. Prof. Shad, welcome.
Thank you so much, Dato, Dr. Venugopal. Assalamu alaikum warahmatullah. May peace be upon you all. I'm indeed privileged to be with so many other distinguished members. I just want to say this to you, Dr. Vino, that as you were speaking, I noticed a dramatic improvement in my hearing ability. You are just fantastic. Doctor, look at what you have done to my hearing ability. Thank you very much. Now, I'm going to give you all of the proclamation of emergency, the COVID crisis, and the Constitution. I have not got the slides going yet. I wonder if the administrators could help me on that. Sorry. Run on this. There you are. All the way up. Yes. Thank you very much, and I apologize for the delay. Now, the aim of my presentation is to clarify some misconceptions about emergency rule and to explain the constitutional role of the Yang di-Pertuan-Agong, the Prime Minister and Parliament during the subsistence of an emergency. I will have a brief mention of whether the battle against COVID-19 could have been fought without the emergency powers of Article 150. 150 is the article about proclamation of emergency. Now, the declaration of an emergency anywhere in the world is indeed a regrettable event because it involves the acquisition of exceptional powers by the government. It's quite obvious that whenever power is enhanced, liberty is necessarily subtracted. However, it must also be observed that exceptional situations call for exceptional responses and exceptional powers. Also, what needs to be clarified is that there are many misconceptions about emergency rule. There is a popular but mistaken view, and I apologize to the lawyers who are present here. Even within the legal community, there is a mistaken view that once an emergency is proclaimed, the Constitution is automatically suspended, Parliament is dissolved or prorogued, sent off on a holiday, Cabinet is dismissed, elections are postponed, human rights are suspended, and the federal government can usurp the powers of the state governments. There is a popular misconception. Actually, none of the above is necessarily true. A proclamation of emergency does not automatically suspend the Constitution or any law or any institution or procedure. I said this to Dr. Venugopal, on my way here, I said we were under an emergency from 1964 to 2011, 47 years. And actually life was going on normally. We were enjoying our right to property, freedom of religion, etc. And Dato Vino was quite surprised that 1964 to 2011, the country was under a state of emergency. So emergency proclamation does not necessarily result in the suspension of any right. However, it does open the gates to the enactment of emergency laws by Parliament if Parliament is in session, or emergency ordinances by the Yang di-Pertuan And I have to clarify here, the Yang di-Pertuan acts on advice. Human rights remain in operation unless eclipsed explicitly by an emergency law. Now, let's go to the 2021 Proclamation of Emergency. Is it constitutional? I have to examine the meaning of the word emergency. Under Article 150, Clause 1, the term emergency refers to threats to the security, economic life, or public order of the Federation or any part thereof. Emergency need not be declared throughout the country. It could be declared in a state or within a division or region of the state. And I think that's what has happened in several states the last few months. In addition to security, economic life, and public order, in the case of Stephen Kalong Ningkan versus the Government of Malaysia in 1968, Sarawak case, it was held by the Privy Council that the term emergency includes wars, famines, earthquakes, floods, epidemics, and the collapse of civil government. So you can see from this quite clearly that the COVID-19 pandemic clearly qualifies as an emergency under Article 150. Why? Because surely we have an economic emergency. We also have the COVID-19 pandemic or epidemic. And may I also jokingly say, there is also an epidemic of party hopping. It is the problem of uncontrolled party hopping. I don't know, you want to call it tang or musical chairs or whatever name. It has led to the collapse of 8 governments since 2018 at the federal and state level. In Sabah, twice. In Perak, twice. That's 4, eh? Federal government, number 5. Johor, Malacca, and Kedah. So 8 governments have fallen since 2018. And perhaps this ground collapse of civil government and the pandemic or epidemic of party hopping was the real reason for the PM's request to the Yang di-Pertuan to invoke emergency powers. However, this ground was not expressed explicitly. Now, the next question is, was the declaration of emergency necessary? Or could we have solved our problems, the economic and health problems, under the National Security Council Act, the Infectious Diseases Control Act, and the subsidiary legislation under these laws? I have to confess that there are many different opinions here, and the answer ultimately depends on your own political opinion. I will give you both sides of the story, then it's up to you to choose. Arguments in support of the proclamation of emergency. The arguments run like this, that the country had no choice but to invoke the extraordinary powers under Article 150 for the following reasons. Number 1, we have a dire economic and health situation in the country, and that qualifies under the term emergency under Article 150. Next one, under the Constitution, if Parliament or State Assembly is dissolved, elections must be called within 60 days of the dissolution. That's what Article 55 says. Now, Elections were becoming imminent due to the rise and fall of 8 governments since 2018. The Sabah election, I think most people agree, caused a nationwide spike in COVID cases. Further, due to untimely deaths of MPs and assemblymen, by-elections were constitutionally required in several states. Here again, the law says if there is a vacancy, then within 60 days, an election must be held. And also the Sarawak Assembly was approaching its 5-year limit. And I think the 5-year limit will expire in July. An election will have to be held soon after that. Is it July or June? I'm not so sure, but I know that by August, the Sarawak Assembly election would have to be held. Also, may I point this out to you, and some of you may disagree with this point, the National Security Council Act and the Infectious Diseases Control Act are ordinary laws. They are not emergency laws, and some of their provisions are being challenged in the courts as unconstitutional. Many of the government's policies and directives since the COVID outbreak, while very well intentioned, are possibly violation of the laws and the Constitution. Some examples could be this. For example, there was a directive on loan moratorium. Don't enforce your loan installments for the next few months. Employers must not terminate their employees, even though they are not coming to work. There should be no forcing of workers to take leave on the days they are away from office. There were restrictions on places of worship. You cannot go for prayers in the mosque, Friday prayers or churches, etc. There was a requirement to wear, I'm sorry, I used the word bracelets, I meant wristbands. You must wear this. There was compulsory testing, movement control orders. Now, many of these raise constitutional issues of personal liberty. In many other countries, cases have gone to the courts. For example, in Germany, the restriction on going to churches or mosques was challenged in the courts, and the courts held the restriction is disproportionate, excessive. People have a right to go to the church and mosque as part of their freedom of religion. All that the government can do is to act in a proportionate way by restricting the numbers. So I want to clarify this to you, those of you who are lawyers. In a rule of law society, power must be derived from the law. It cannot be derived simply from notions of necessity or public good. I know many people will say, look, if it is just, if it is fair, if it is necessary, if it will be for public interest, the power exists. And now I'm afraid it does not exist. Rights are inherent. Power must be derived from the law. So if there is a contract between a bank and a customer for a particular loan to be paid in a particular way, a minister's or Bank Nagara's directive cannot just wipe away that contractual obligation. So I'm just trying to point out to you that the existing laws may not be adequate to solve the problems. Emergency powers may be needed to take temporary possession of private land, building, movable property, something that was mentioned earlier. The demand to use hospitals and medical resources, to enlist specialist manpower, to put a monetary limit on compensation. I just want to alert you, Article 13 clause says that if you take away my property, and the word property is very broad, you must give me adequate compensation. But the emergency law says, now it says that the monetary compensation may not be adequate. It is as determined by the executive. Surely that's unconstitutional. But Article 13, the right to property and right to compensation, can be eclipsed by the emergency law that has been drafted, the ordinance. There are requirements of compulsory treatment, immunization, observation, surveillance, and there is a possibility now of using the armed forces for civilian purposes. So I think these extraordinary powers were needed, and that's why the emergency proclamation and emergency ordinances were enacted. Under the Emergency Prevention and Control of Infectious Diseases Amendment Ordinance 2021, there may be an order for wearing of tracing devices. What if I say, no, I don't want to wear? Well, under the ordinary laws, I may have a constitutional argument to resist this command. But if there is an emergency ordinance, as there is now, I cannot resist, because my personal liberty, my freedom of expression can be suspended by an emergency law. Also, elections were due in many constituencies for bylaws. In Sarawak, for the state election after 5 years. But during the period of this emergency, no federal or state elections will be held. Hopefully, this will prevent spread of COVID-19. Now, the declaration of emergency has put a stop to the endemic political instability. The political musical chairs, this lompat-lompat, has hopefully ceased. Party hoppers are now deprived of the nefarious opportunity to bring about the fall and rise of governments, as has happened 8 times between 2018 and 2020, as I mentioned earlier. The Emergency Ordinance EMO 2021 contains a sunset clause. In other words, there is a time limit on this emergency. May I mention to you, all the previous emergencies from 1964 onwards never had a time limit. But this emergency ordinance specifically has a sunset clause which says by August 1, this ordinance will expire. Also, a special committee has been constituted by the Ordinance of 2021 to advise the Yang di-Pertuan and the government on the COVID emergency. This is similar to the National Operations Council of 1969. However, I don't have the time, but I'll just mention to you, the EMO of 2021 does not confer on the special committee the kind of vast powers given to the National Operations Council and to Allahyarham Tun Abdul Razak in 1969. In 1969, the National Operations Council had virtually unlimited powers, but in 2021, the powers are much narrower. Now, if there is political stability and continuity achieved by declaration of emergency, this may help economic recovery and invite foreign and local investment. You may say, how can that be so? Foreign investment will not come if the country is under emergency. May I remind you that the good economic years of Malaysia before the 1 MDB saga were the emergency years of 1964 to 2011. Those were good years of economic growth, and many of us do not know. Actually, those were years of the emergency. Also, one effect of these emergency laws is that the role of the Yang di-Pertuan as a statesman, as a reconciler, as the balance wheel of the constitution has been enhanced. The Conference of Rulers has gained importance. It is noteworthy that since 2020, many other states like Japan, Thailand, Philippines, Indonesia, Italy, Finland, France, Australia have declared full or partial emergency. I think about 18 countries that have declared total or partial emergency. May I point out that with all its faults, democracy is worth preserving. However, it is a legitimate question. If a nation must be allowed to perish in order to save its democracy, The emergency proclamation of 2021 is certainly no cause for celebration. However, it may have its silver lining, and I mentioned some of the points in support. However, I now present the other side of the story. The emergency was declared to prolong the life of a minority backdoor government. That's the allegation. The emergency is for the undoubted benefit of the current minority prime minister. The emergency undermines parliamentary democracy and prevents a return to the electorate, because elections have been suspended, federal and state by-elections have been suspended. So we are unable to return to the electorate. Parliament and the state assemblies have been marginalized and prevented from performing their function of keeping the government answerable, accountable, and responsible to the elected legislature. May I point out to you that actually the idea that during an emergency, Parliament must be compulsorily sent off on a holiday is totally wrong. It is antithetical to what the Constitution spirit is. In fact, under the Constitution, Article 150, Clause 3, if the Yang di-Pertuan proclaims an emergency, his proclamation must be presented to Parliament, and Parliament has the power to annul the proclamation. Parliament has the power to annul the proclamation of the Yang di-Pertuan. And if the Yang di-Pertuan formulates or promulgates, we say, emergency ordinances, that ordinance must be laid before Parliament, and Parliament has the power to reject the ordinance. Thirdly, under Article 150, Clause 5 and Clause 6, Parliament has the power to enact emergency acts of Parliament. And fourthly, under Article 43, Clause 4, 43, Clause 3, Parliament has the power to keep the government on its toes, to keep it answerable, accountable, and responsible. So even during an emergency, Parliament continues to perform 4 very significant constitutional functions. And obviously, these cannot be performed because of the declaration of emergency and the provision which says that Parliament and the assemblies cannot meet unless the Yang di-Pertuan fixes a date for their convening. Now, I go to the next one, the Emergency Essential Powers Ordinance 2021, a critique. Some of the points were made earlier, so I'll go through very quickly. Ordinance has some provisions which are likely to attract national as well as international criticism, especially from many foreign chambers of commerce and intending investors. For example, there is now a power on the part of the executive to take temporary possession of land, building, movable property, and assets, not just a hospital's ward or operation theater or intensive care unit. Even assets can be taken over. That's something that I'm sure companies, foreign companies will not be very happy to hear about. Under Section 4, Clause 4, not only human resources, facilities and utilities can be taken over, even assets can be taken over. There is the question of compensation, and when these are taken over, the compensation will not be according to market value, but according to what the executive determines. So it will be reduced compensation. The penalties under Section 9 are incredibly harsh. Just give me a minute, 5 million ringgit or imprisonment for a term not exceeding 10 years. These penalties are very, very frightening indeed. There is suspension of Parliament, and many people say this is a violation of Article 150, Clause 3, which I pointed out to you. Under Article 150, the emergency article, Parliament actually has important constitutional functions. Now, if Parliament is not in session, how will it perform these constitutional functions? So critics are asserting that sections 14 to 15 of the Emergency Ordinance 2021, which suspends Parliament, is a violation of the spirit of Article 150, Clause 3. If Parliament remains suspended during the emergency, how then will the proclamation and the ordinance be laid before Parliament? There is no accountability to Parliament because though under Section 11, the Prime Minister on the date of proclamation and the Cabinet and in the states, the Mantri Basar, Kato Mantri and their exco, they remain in place. They remain in place, but Parliament has been sent off on a prolonged holiday. Now, is this unconstitutional? All of you who are lawyers will know that, of course, there's no bar to going to a court and raising this issue. Attorney General will undoubtedly rebut the above arguments by pointing out that since 1981, the Constitution was amended in 1981, the role of Parliament during an emergency has been drastically reduced by a constitutional amendment in 1981. Prior to 1981, Article 150, Clause 2 used to say that if a proclamation of emergency is issued, then Parliament shall be summoned as soon as may be practicable. So that was the law. If proclamation is issued and Parliament is not in session, Executive has a duty to summon Parliament as soon as may be practicable. These words have been deleted. Prior to 1981, if even one house was in session, even if one house of Parliament was in session, the Yang Ipartonagong could not promulgate an ordinance. He could promulgate an ordinance only if Parliament is not in session, and so he steps into the shoes of Parliament. This law has been changed. Now, if the two houses are not in session concurrently, the Agong has parallel lawmaking power. May I please inform you, the two houses never sit concurrently. So if today Dewan Rayat is in session, if it is in session, Agong still has the power to promulgate emergency ordinances. So since 1981, it appears during an emergency, the executive rule without a parliament is not unconstitutional. That's what the AG's office will argue. General elections have been postponed, and rightly so, people will say if parliament is dissolved, then elections must be held to elect a new parliament, but none of this is possible. Neither the elected parliament is in session, nor elections are possible to bring about a new parliamentary government. May I also point out to you that under Article 55, if Parliament is sent off on a holiday, no more than, sorry, I made a mistake here, typing error, no more than 6 months must pass. It's not 60 days, no more than 6 months must pass between one session and the next. If Parliament is dissolved, prorogue is it goes on a holiday. If Parliament is dissolved, then no more than 60 days must pass between the dissolution and the calling of a new election. I apologize, there's a serious typing error here. So under Article 55, the maximum life of Parliament is 5 years. This means that the present Parliament must dissolve in 2023. However, this is the inelegant piece of drafting. Perhaps it was not intentional, it is just a case of inelegant drafting. Section 12 Clause 4 and 14 Clause 1 of the Emergency Ordinance provide that Article 55 of the Federal Constitution is hereby, let me just get to the, Article 55 is deleted. If Article 55 is deleted, then the life of Parliament of 5 years is also deleted. Does this mean that if the emergency is renewed on August 2021, does this mean that the present Parliament can continue beyond its lease of 5 years and the present MPs will remain as MPs beyond 2023? Or will this mean that there'll be no Parliament at all? I don't know. All that I can say is this: Article 55 has been deleted during the emergency, which means there is no time limit of 5 years. So I think this is something that needs to be looked into by the Attorney General's chamber. So the suspension of the 5-year rule in Article 55 may create the wrong impression that a long period of emergency beyond 2023 may be envisaged. Section 12, Clause 4 is extremely harsh because during an emergency, no election shall be held. As I was mentioning to Dato earlier, Dato Vinu, that actually in the past, 11 elections were held between 1964 to 2011. 11 elections. Why can't an election be held again despite this emergency? I also want to alert this to you, and I know it doesn't affect you and me, but it may affect our children. So please just be briefed. A politically dangerous fact is that though the Constitutional Amendment Act of 2019 made some scintillating changes, I call them scintillating, you may disagree, of course. The changes were the following: voting age was reduced from 21 to 18. There was to be automatic registration, no need to register. If you are registered with the National Registration Department, automatically you're registered as a voter in the constituency which shows up in your birth certificate or where you had previously registered. Thirdly, the age to contest as an MP was reduced to 18. Fourthly, the age to contest as an assemblyman was reduced to 18. Now, 3 of these 4 amendments, sadly, required follow-up action by Parliament or by the AGC or by the Election Commission. I'm sorry to report to you that the reduced age of voting in Article 119, the requirement for automatic registration, these provisions have not yet been given effect by gazetting them in the Warta Kerajaan. When the Amendment Act of 2019 was passed in July 2019, it was gazetted in September 2019. But the Act itself has a clause 1, subclause 2, which says that amendments to Article 119 is the voting age and automatic registration. Those amendments require a special notification from the Yang di Pertonagong. That has not been done. Also, to reduce the age of qualification for a state assembly requires amendments to all 13 state constitutions. That has not been done. So I want to alert you all that our kids, if they are hoping to vote at the next election, I hope their hope will not be belied, because the consequential amendments have not been made yet. Now, there are a few other dilemmas for the king. Dato, I'll just take 3 or 4 more minutes. There's a dilemma for the king in relation to the position of the PM. Despite the declaration of emergency and despite the provision in the emergency ordinance that the PM and the cabinet, the Mantri Basar and the Exco who were holding the post at the time of the declaration of emergency shall continue in office. Despite that provision, there is this possibility that 111 out of 220 MPs, by the way, it's 222, but there are 2 vacancies. So that's why it's 220. Majority will be 111. If 111 MPs send a petition to the Yang di-Pertuan Agong and say, we have lost faith in the Prime Minister who is occupying the seat now. What should His Majesty do? Should His Majesty still continue with the existing Prime Minister? Or should His Majesty try to find out whether the claim that someone else has a majority is correct? But by the way, after the Perak precedent in the Nizar case, it is now possible for a ruler, for a governor, for the Yang di-Pertuan Agong to take note of factors outside the House. The House is not in session, but if there is a statutory declaration or a statement in some other way given by 111 MPs to the Agong will be on the horns of a dilemma. Suppose the Yang di-Pertuan Agong decides to follow Article 43, Clause 4, which says if the Prime Minister has lost confidence, then he must either resign or advise dissolution. Agong may say dissolution is not desirable for a new election because of COVID. So you have to resign. Suppose the Agong appoints a new government. What's the guarantee that in a few weeks' time, the party hoppers will not start hopping again? So will the Yang di-Pertuan Agong then go through another musical chairs? So I think this is a real dilemma for His Majesty the Yang di-Pertuan Agong. And my humble suggestion is that His Majesty must contemplate an anti-hopping ordinance, later to be converted into an anti-hopping law, before summoning Parliament or appointing the next government. Many people are in favor of the Yang di-Pertuan Agong summoning Parliament so that Parliament can keep the executive under check. But if Parliament is summoned and there is this hopping going on again, I think this is going to create too much instability. So I think we need an anti-hopping law. There are many models available. There are many controversial issues, but they can be overcome. States, state assemblies, state excos, during an emergency, their powers can be taken away, can be. Not automatic, they can be taken away. For example, Sarawak State Assembly is due for dissolution and state election was on the cards, but now of course, there'll be no election. Some people want to challenge the emergency. In fact, there are 3 cases pending in the courts, and it's up to the courts whether to decide this way or that way. May I just point out to you that the lawyers, I'm skipping 1 or 2 slides, the lawyers who are challenging the declaration of the proclamation of emergency, the drafting of the ordinance, they are relying on a British case, the case of Miller number 2. What had happened was this, that in the UK, Prime Minister was facing massive challenge to his Brexit policy. Boris Johnson was facing massive opposition in Parliament to his Brexit policy. So he decided to approach the Queen and said, prorogue Parliament, send it on a holiday. And the Queen followed his advice, prorogued Parliament. Number of cases went to the courts, and the argument before the courts was the Prime Minister has acted mala fide, in bad faith. He is preventing Parliament from performing its high constitutional function. Parliament is the grand inquest of the nation. It is its job to keep the executive answerable, accountable. So the courts, for the first time in British history, they declared that the advice by the PM to the Queen to prorogue Parliament was unconstitutional, an abuse of power, and Parliament is therefore still in session. So I think many lawyers may argue like this. They may rely on the Miller number 2 case from the UK. Whether our courts will follow Miller or not, I do not know. I think our position is slightly different. In this country, Article 150, Clause 8 clearly says that the proclamation of emergency by the Agong, the making of emergency ordinances by the Agong cannot be questioned in a court of law. Article 150, Clause 8 contains what we call in law an ouster clause. Judicial review, judicial power is ousted. So will the courts follow Miller, or will they rely on Article 150, Clause 8? And Dato, we know this is my last point. What are the repercussions of the declaration of emergency? Just one last point, 2 minutes. Well, the repercussions are unknown. Much depends on the success or failure of remedial measures under the emergency. Will the economy improve? Will the COVID curve go down? One can only guess what these repercussions may be. My guess is this, that there will be calls for amending the Constitution to the pre-1981 role of Parliament during an emergency. Many people will say, lawyers will say, amend the Constitution again, make Parliament more powerful during an emergency. If the reconvening of Parliament results in a vote of no confidence, the King will be faced with several things I pointed out. So there will be this demand for either an anti-hopping law. If anti-hopping law is not passed, that to report to you, what will probably happen is Malaysia will be in an era of minority governments. Many countries which have parliamentary democracy have the problem of minority governments. My reading was that there are in the present time nearly 17 or 18 governments, parliamentary democracies in the world with minority governments. The Prime Minister does not have majority support, so he survives on a day-to-day basis. May I point out to you, in Belgium, the caretaker Prime Minister was caretaker for 18 months, 1/8. That's remarkable. So Malaysia may be headed for an area of minority governments. Of course, the call for a new election will mount. Sadly, elections have been halted because of the COVID-19 crisis. We have to wait and see what the future will hold. Malaysia is, in my view, suffering from several crises. First of all, the COVID-19 pandemic. Secondly, the economic devastation that COVID has wrought. And thirdly, the epidemic of party hopping. I call that also an epidemic of party hopping that has caused so much political instability and loss of direction. Let us pray that there is light at the end of the tunnel and that we can overcome all three of these crises. Thank you very much. Thank you very much, Dato.
Thank you very much, Prof. Shad, for that amazing lecture. And let me quote one of the senior lawyers who has commented in one of our chat groups that the lecture was so eloquent in a simple and unassuming way, so unlike lawyers. Maybe you do sound like a doctor about to take consent for a major surgical procedure. And when I first spoke to you over the phone, I told you that it would be nice if the talk was a bit provocative. And I must admit that you have far exceeded our expectations.
Thank you so much.
And I think the general tone is one that I think reiterates the fact that Malaysia could have gone forward without actually proclaiming the emergency. And that is a sad reality of the nation's politics, I think. Now, there are one or two very important questions, and I would like to start with one. It says, Prof, that Section 10 of the Emergency Ordinance 2021 provides legal protection to the government and public officers. This legal protection is conditional upon their acts or omissions being done in good faith. So, in your opinion, Prof. Shad, how would you define good faith? I think your computer is hanging. The worst comes to worst, you can just walk across.
Yes, we are doing that now.
Yeah. That's the advantage of having the speaker and the moderator in the same building.
I apologize. I don't know what I did.
Are you on screen now?
Yes, he is.
He is? All right. So did you hear the question?
No, I didn't. I heard the word Section 10.
Yeah, okay. So the question was that Section 10 of the Emergency Ordinance provides legal protection to the government and public officers. This legal protection is conditional upon their acts or omissions being done in good faith.
Yes.
Now, in your opinion, what is good faith?
Well, good faith has been actually defined by the courts in many cases. Basically, it means no ill motive, no abuse of power, no using the power for personal benefit. It's a very large term. It's a very large term. Basically, it means no abuse of power.
Okay.
And the courts are the best judge of what is good faith or bad faith. The courts are generally reluctant, and I have to say this with some sadness. The courts blow hot and cold in the same breath. On the one hand, they will say bad faith can be pleaded in a court. On the other hand, they say the burden of proving bad faith is upon you, the complainant. It is not the officer who has to prove his good faith. It is you who have to prove that he acted in bad faith. And sometimes it's very difficult to prove. The issue of bad faith succeeds in the courts, I would say, in only 1 out of 20 cases, maybe. Bad faith is very difficult to prove. So this is not a very good defense. However, let me also just point out, many other laws, for example, the Government Proceedings Act, Specific Relief Act, Public Authorities Protection Act also give to the government certain amount of immunity. So it's not an unusual law at all.
One other question, Prof, is from one of your former students, Dr. Faruqi Uzair. And he says, can I get your views on whether the quarantine ruling for ministers being limited to 3 days, can it be challenged as being unconstitutional under Article 8 of the Federal Constitution?
Article 8, Clause 1 says that all persons are equal before the law and entitled to the equal protection of the law. I think Article 8 necessarily implies that not only there must be equal protection, there should be equal harassment. So I think treating different people differently is, on the face of it, it would appear to be unconstitutional. However, the law clearly recognizes what is called reasonable classification or differentiation. So I would say the burden here would be on the maker of this directive or maker of this regulation to say, how come ministers are in a separate category than ordinary citizens? It has to be a reasonable, a rational classification, and the judges will be the best judge of that. I would be very surprised if any judge were to uphold this to be a rational classification. I'll be very surprised. I think this, on the face of it, to me, appears to be a violation of equality before the law and equal protection of the law. The general principle in constitutional law is that no matter how high and mighty you might be, the law must apply to you equally.
Yeah. So there is one important question regarding vaccination and immunization. It says here, immunization is part of the Infectious Diseases Act, but we do not punish anyone in that act for refusal to take the vaccine. But right now there are, so many statements from very different sources, including the DG and including some of the ministers, who say that it might come to a stage where you can be punished. Now, is that appropriate?
Dato, I would think that refusal to take an inoculation would be part of personal liberty in Article 5 clause 1. People would have a right to say, I don't trust this, I want to protect myself from the law of defamation, and I don't trust this XYZ inoculation.
Yeah.
I'm prepared to take the risk. And I think there would be issues of personal liberty in Article 5. But during an emergency, under an emergency ordinance, personal liberty can be suspended.
Yeah. So this is where, I'm not legally trained, but I get the impression as a lay person that this whole drama of the emergency is an example of the law letting us down, isn't it?
Yes. Well, yes.
I don't think that there were enough checks and balances. So is it a problem with the Constitution? Is it the problem with the law? How was it that this was allowed to happen in the first place?
Actually, Dato, I have a slightly different perspective. I said, I think that Malaysia surely is under a COVID emergency. The number of people who have died may not be as much as in the USA or UK, but surely there are people who are dying, there are people who have lost jobs. So we were under an emergency, but the emergency could have been tackled as a medical emergency rather than the issue of sending Parliament off, assemblies off, and some of the very drastic provisions that I pointed out. Assets can be taken over, not just the hospital's operation theatre, but the assets. Assets is a very large word. Yes, I think there has been an overzealous use of the law, but the hopeful point is this emergency is only up to August 1. 6.5 to 7 months, and hopefully from it'll come to an end. But as I did point out, there's nothing to prevent the government from extending the emergency. This ordinance comes to an end today, another ordinance can be issued tomorrow.
Well, so finally, since you mentioned party hopping on more than one occasion, there is a question which says, do you think an amendment to this point would be agreed upon by the same people when it actually enhances their financial status in doing so?
Yeah, sadly, party hopping has arouses the deep suspicion that this hopping is not based on principle. It's not the kind of hopping Winston Churchill did when he left his party and joined another party and then came back. This is hopping for personal aggrandizement, promise of a post or promise of something else. Whether they will agree to it or not is speculative. During an emergency, Agong can issue an ordinance, whether they like it or not. It will be a question of leadership. And I think leaders of substance should not follow opinion polls. They should do what needs to be done because of the, the power of their souls. I think they should do what needs to be done. I think we need an anti-hopping law. But by the way, many people are against anti-hopping law on the ground that, not because they favor unethical practices, on the ground that it is freedom of association. I have a right to associate, I have a right to disassociate, I have a right to re-associate. They feel it's part of freedom of association. They also feel that even if you pass an anti-hopping law, it may not achieve its purpose because I may be in your party, and so I won't hop against you. I won't leave the party. I will just vote against you. While remaining under your umbrella, I will vote against you. So actually in India, they have tried to tackle this issue. If you vote against your party, that is regarded as hopping.
All right.
That too is regarded as hopping. If you disregard the whip, WHIP, whip of your party, that is regarded as hopping. So we can solve this problem. The main difficulty here would be this, Dato, that in a case decided by the Supreme Court said that Article 10, Clause 1, bracket C, on the right to association includes the right to hop. So the Supreme Court gave its blessing, legal blessing, to the right to hop. In this case, there was a Kelantan law against hopping. The court wanted to invalidate the Kelantan law, and there was also the Sabah law, and therefore they said, I totally disagree with this Nordin Salet decision on this ground. There is freedom of association, Article 10, Clause 1, Subclause C. But there is restriction on the right to association. Parliament is allowed by law to impose restriction on grounds of security, public order, and morality. Morality. Morality doesn't only mean sex morality. Morality also means political morality. Party hopping, in my view, is immoral because I go to the electorate wearing a songkok. Elect me. After they elect me, I take off my songkok, I put on a sarban, or I put on something else. Now, I think there is a little bit of a fraud on the electorate. It is misrepresentation. I stand for this at election time. After I got elected or soon after that, I suddenly stand for something else. I think there is a fraudulent misrepresentation. So I think this decision should either be overturned by our court, but that will take time. Because you go through the High Court, the Court of Appeal, the Federal Court, or there should be a parliamentary law, parliamentary amendment to Article 10. At the end of Article 10, it should be provided that the term right to association in 10 Clause 2, Subclause C does not include the right of a party member to change parties midstream.
Thank you so much, Prof. I think we have gone 15 minutes beyond our scheduled time, but it was an amazing lecture without doubt. Thank you so much. We have got so many positive comments on our chat group. And ladies and gentlemen, I think we have come to the end of a very interesting 2-hour session, MLSM's first event for 2021. We will continue to host webinars and in the future, if possible, physical events. Before I conclude, I would like to sincerely thank Sean Delamont for allowing us to use the Zoom platform. And I would like to thank each and every speaker and moderator who did more than going out on a limb to make sure that today's function was a success. And most importantly, last but not least, all the 230 people who actually attended today's webinar. Thank you so much. Bye-bye, greetings, and see you again soon. Thank you.
Thank you so much. Thank you.
Thank you. It was fabulous.
Thank you so much.